Hi everyone, nice to meet you. As she so kindly said, I am Dr. Madeline Russell. Fairly new to the area. Like she mentioned, I did my residency down in Savannah, and the group that I am associated with is based out of Savannah, but I am full-time in Hardeeville, working with Coastal Carolina Hospital and the Okatee surgery area. I'm here to talk to you about the big beast that is GERD and acid reflux, and one of my colleagues, Dr. Montenegro, one of the surgeons, is going to discuss new surgical opportunities for treatment. I'm going to go over the traditional kind of etiology of GERD and how it's medically managed. I'm assuming, since we're all here, that everybody here has either suffered from GERD themselves or had a loved one that has had problems with acid reflux. If there's any questions, I believe we'll take them at the very end of the session. Okay. So we're going to go over just understanding some general principles of gastroesophageal reflux disease, or GERD, and then the medical surgical management, and then Dr. Montenegro is going to discuss a novel approach of incisionless surgical therapy for the treatment. All right, I think we all know about it. Just a little touch of heartburn. We've all had it. We've all been bugged by it. We've all woken up at 3 a.m. and saying, dang, I shouldn't have eaten that taco, or whatever it may be that elicits the sensation in everybody. But it is very common. What heartburn and acid regurgitation actually produces symptoms typically are that burning sensation in the middle of the chest, a sour taste in the back of the mouth. Times that is probably worse and symptomatically worse for patients would be at nighttime, large meals. We just had Thanksgiving holiday. If you guys overate for that, you can understand where maybe you were up half the night experiencing some of those symptoms. Water brash is that sensation of the sour taste in the mouth and the burning sensation in the stomach. It also produces that excessive salivation that we can experience sometimes in the mouth. You don't have to have all of these symptoms to have it constitute your true physiologic manifestation of GERD. And then some complications of GERD can be dysphagia and odynophagia, probably more so dysphagia than the odynophagia. And dysphagia is just a fancy word for difficulty swallowing. Odynophagia means painful swallowing. So you can imagine if you've had reflux and there's been irritation and acid has come up into your esophagus and burnt it, you could have trouble getting things down, and it obviously could be painful. GERD has other symptoms as well. It can manifest in the pulmonary system in our lungs by asthma, chronic cough, chronic bronchitis, and aspiration pneumonia. Might know somebody that chronically goes like or has a nocturnal cough. That can be some of the manifestations of GERD in the lungs. Other types of symptoms we can get can be true regurgitation of food and of bile and stomach product, the typical chest pain, and then dental erosion or dental caries, poor dentition overall because acid can burn through the enamel layer of our teeth. Ear, nose, and throat conditions, hoarseness, laryngitis, the sore throat that we already mentioned, the chronic cough that I mentioned, frequent swallowing, not to be confused with the frequent swallowing I'm having from talking up here, but frequent swallowing after you eat meals and having to feel like you're pushing the food down, as well as burning in the back of the throat and the mouth. Just some general anatomy of the stomach and the esophagus, and this will help educate on the physiologic causes of GERD. Here we have the esophagus. I'm not sure if I have a pointer up here. No, maybe not. Does the mouse work on there? You guys see that? Perfect. That'll work. Okay, so we have the esophagus coming down. Here you have the diaphragm. We have the diaphragm here, and then you can see the outline of the stomach here. That is the upper portion of the stomach. What composes the lower esophageal sphincter are the muscles of the esophagus, and actually the end point here of the diaphragm where it connects. And the lower esophageal sphincter is very important in the etiology of GERD because it is the barrier that keeps contents in the stomach versus back up in the esophagus. And it's also what allows food to pass down from the esophagus into the stomach. So disruptions in the lower esophageal sphincter or relaxation of the lower esophageal sphincter can cause a breakdown of this barrier and obviously make it nearly impossible for food to not go somewhere, either up or down. The Z line here is listed. It's a mucosal finding, and it is the true change of mucosa from the esophagus, the mucosa being the lining of the esophagus, and how it differentiates from the lining of the stomach. So that's what the Z line is. It doesn't really have a physiologic role in any part of GERD, but it's a marker that we as gastroenterologists will look at when we perform upper GI endoscopy to look down in your esophagus and see where the esophagus ends and the stomach begins. So it's kind of like the end point of the esophagus and the beginning of the stomach. The angle of His is just this little area here where the diaphragm connects in, the diaphragmatic muscle connects into the esophagus. And here we have the fundus of the stomach, which is just the top part of the stomach. And then you have this gastroesophageal flap valve. I think we just colloquially call it the GEV. It is the top of the stomach that, as you can see, there is an angle of muscle here, which is where the stomach is, and it kind of comes down. It's another little barrier of protection to keep things from going up in the stomach, but physiologically doesn't have to be incorporated into the development of GERD. So what happens when we develop GERD is we have these components that contribute to its development, which could be esophageal clearance of acid, meaning letting the lower esophageal sphincter relax so acid can go down and preventing the contents of the stomach from coming up. You have the mucosal lining of the stomach, which is resistant to acid. It produces the acid, and it also has a functionality of producing mucus that is a protectant layer so the stomach doesn't digest itself. And then the ability of the stomach to clear the acid can contribute to GERD, because if you have a blockage or decreased ability to get food out of the stomach, like I mentioned, it has to go somewhere, and that's up. The duodenal gastric reflex is, or duodenal gastroreflux, is when perhaps food gets into the small intestine where it connects to the stomach, but then food also comes back because of poorly compromised sphincter that is there as well. The extrinsic factors that play into GERD, like I mentioned on that anatomic position, occur when there's a deterioration of the natural barrier, meaning you have breakdown of that lower esophageal sphincter here, and either the diaphragmatic muscle can be weakened, or part of the stomach is able to slip up through a larger hole in the diaphragmatic muscle, or the lower esophageal sphincter comes down further, and then you have tension from the diaphragm here, and then the tension from the lower esophageal sphincter there. So you get a little bit of a disconnect, which can cause food to get stuck in that small little area between the diaphragm and the stomach. Here is an endoscopic picture of normal anatomy. This picture here is showing normal anatomy. Here is the endoscope, and you can kind of see, maybe in this really tiny picture, the endoscope is going down through the esophagus into the stomach, and then it's almost candy-caning back up to take a picture. That's what this is showing here. So we have the scope coming down and staring back up at the top of the stomach where it came through the esophagus, and that's showing this area of the GEV, or the gastric flap, and then the lower esophageal sphincter would be within that area as well. So when there's disruption of those barriers, you see this physiological finding. Here you see space between, versus if I go back, this is tightly wound around the, is my mouse showing up there? Okay, yeah. Tightly wound around the scope, creating a tight barrier, meaning there's nothing able to get back up. Food can't slip up, acid can't slip up back into your esophagus. When there is disruption, you get this large space here. That can be the formation of a hiatal hernia, or it can be a sliding hernia, and it's typically caused by relaxation or an abnormal opening in the diaphragm. Stuff that is in the stomach can't stay there because of pressure from digestion. It comes back up. So just some basic facts about GERD. 10 to 15% of the adult population suffers from daily GERD. I feel like in my practice it's more like 95%, but that's because that's what I treat day in and day out. The incidence of GERD rises rapidly after 40 years of age. I would also add in there that the incidence of GERD rises with increase of weight. GERD gets worse over time, typically, and early correction can prevent deterioration of the natural barrier, meaning if you treat GERD early when you first start to have symptoms, you won't have the chronic injury occurring to that area that further breaks down the lower esophageal sphincter's ability to stay closed. An important fact to note is that patients with GERD are 8 times more likely to develop esophageal cancer. So If patients have weekly heartburn or regurgitation of acid, they have a higher risk of developing esophageal cancer, which precludes to its importance of why we want to treat it. Physiologic reflux can develop into symptomatic GERD, and then you get esophagitis, which means inflammation of the esophagus from the acid breaking down the tissue there. And then you can get complicated esophagitis. Complicated esophagitis can be ulceration, where you get that true odynophagia, which is the painful swallowing. You can have bleeding from the esophagus. You can develop stricture or narrowing because scar tissue develops over that area. Or you get this precancerous condition called Barrett's esophagus.